everybody. Welcome to this live. I'm Aarti Shah, and today we're covering the topic about endometriosis excision, the accessibility, management, and treatment here in Kenya. I'm just going to wait for Dr. Joe Jaggi and Dr. Yamal Patel to join in. As soon as they've joined, we can carry on with this live. So please bear with me, and thank you all for joining. I'm just going to wait for them to join, so please bear with me. I'm just waiting for Dr. Yamal and Dr. Jaggi to join in. As soon as they join, we can start this live. In the meantime, hope you're all well. Hope you've had a blessed weekend. Okay, I can see Dr. Yamal has joined, and he's requesting. Hi, Dr. Yamal.
Hi. Good evening. How are you, Aarti?
Good evening. Good, thanks. How are you?
All well. Thank you.
Thank you so much for joining. And we're just going to wait for Dr. Jaggi to join in. But in the meantime, once you've settled, I guess I can introduce you as we wait for Dr. Jaggi to join in.
Yes, please.
All right. So thank you, viewers. Thank you, Dr. Yamal. As we wait for Dr. Joe Jaggi, let me introduce you to Dr. Yamal Patel, who's a consultant obstetrician, an advanced MIS surgeon, that is minimal invasive surgery. He's an endometriosis surgeon as well. He's a director at the Third Park Hospital here in Kenya, especially Nairobi, right?
Yes.
Correct me if I'm wrong. And the ex-board member of ISGE and the member of AAGL and the RCOG. He's a trustee at LAPMASH. We will get into LAPMASH later on. But welcome and thank you for joining me, Dr. Yamal.
Pleasure's mine. Thank you, Aarti.
So Dr. Jaggi said he will be joining us shortly. I'm just going to wait for him. But I've introduced yourself. Is there anything that I've missed out on your introduction that you would like to tap into or add in?
No, I think that's fine. Thank you. Covered well.
Yeah. Okay.
So how's your evening today?
My evening is all right. Thank you.
Good.
It's been it's a chilly evening today. So
Yes.
How has your evening been and your busy workshop weekend?
Yeah, evening's been good. Yesterday morning and up to today afternoon was a bit hectic. I had to take a nap in the afternoon, but I think that's it. Had to look fresh for this.
Thank you. We truly appreciate it. Especially when doctors go out of the way to put our endo community on the limelight, on the forefront. It truly means a lot. So thank you.
Thank you. Yes, I was with Dr. Jaggi earlier today. I think he just called me. He's just gotten back home. He was in Nairobi with us. And
he's actually just joined.
Yes, he was with us.
So him to send me a request.
Yes.
He's just joining. So as soon as he sends me a request to join the live, I can add him on.
Yes.
Hi, Dr. Jaggi. Can you hear us? Oh, there we go. He's just added. Let me just hang on. No. Wrong. Dr. Jaggi, if you could just send me a request. I'm just waiting. Sorry. Sorry, everybody. Hi, in the meantime. Hi, everyone. Thank you for joining us as we keep having new um, warriors join in. Okay, just a second. There we go. I've just accepted his request. He's joining in. There we go. Hi, Dr. Jaggi.
Hey, how are you doing, Artie? Hey, Yama.
Hi.
Yeah, good to see
I'm
both of you.
good. Thank
Looks
you.
looks
Good to see you too.
looks like
Thank
you
you
just
so
walked out of your car and into this.
I just did. You're right. Yeah, I just did a few minutes ago here. Yeah, yeah.
Yes.
He literally did. Thank you so much, Dr. Jaggi, for joining in as well. Whilst we were waiting for you, I introduced Dr. Yamal. So kindly let me introduce you, and then we can kickstart this session.
Sure.
All right. So welcome, Dr. Jaggi, and welcome, Dr. Yamal again. Dr. Jaggi is an obstetrician, gynecologist, and a laparoscopic surgeon. He's an endometriosis specialist, and he too is a director at the Third Park Hospital. He's the member of the International Society of Gynecological Endoscopy. I always get that word wrong. Sorry. Excuse my pronunciation. He's also a member of the World's Endometriosis Society and the European Endometriosis League. Welcome, Dr. Jaggi.
Thank you. Thank you
Have I
for
missed
having
out on
me.
your introduction?
You got it perfect. Yeah.
Okay, great. Thank you. Thank you so much. Thank you all. Thank you to both your doctors for joining us, and thank you all for being on this live with me. And let's continue to change the narrative about endometriosis here in Kenya.
Yeah, precisely. And I should say
Sure.
myself that you're doing such an excellent work. And yeah, we got to talk about it for obvious reason, which, you know better. So I would say it's really humbling for me to be part of this narrative and talking about endometriosis, honestly. More importantly, in our setup.
Definitely. Thank you. Thank you. Are we all for the viewers, are the three of us audible? Could somebody just type in to say if we're audible? Because I know the three of us can hear each other, right? So
Yes,
I'm
we can.
assuming that we should be.
Testing 1, 2.
I like that mic test 1, 2, right? Fine. Okay, so let's jump into it. I'm hoping, yes. Okay. Hi, Doris. Doris is saying yes, we are.
Thank you.
Great. Thank you. All right. Should we jump into it? Thanks, Dr. Shilpa. All right. So, doctors, I'm going to address the questions to both of you. This session is just about seeing how we're changing the narrative about endometriosis here in Kenya, and what we're doing to grow the community and be a better workforce for the entire endo community here. Okay.
Sure, sure.
Yes.
So, how long have you been specializing in endometriosis?
I think I'm the
So
younger one here.
yes, so I'll take a go at it first. I mean, I've been practicing as a consultant from 2003, and I've been working with endometriosis right from then, but I've been doing more detailed endometriosis work over the last, I would say, 5 to 7 years.
It's very important for me to mention that I'm a mentee of Dr. Yamal Patel, and so I've been kind of riding, along. And I still remember when I started working with him. There should be about 6 years, 6 years ago. He was very keen in endometriosis. And honestly, I didn't know what was endometriosis, just to bring it to this, context. Had not heard much about endometriosis because it was not trained during our residency. And over the years, I would say, of course, mine is chugging along him, and picked up, I would say, 3, 4 years for me.
That's wow, amazing. And this is what I love about the two of you, you know, and other handful of doctors. But right now we're discussing with you two. I just love the transparency, you know, it's so important because as an endometriosis patient, transparency is so, so important. You know, that defines a lot about who we actually end up going to for treatment.
Right, right.
So,
So, have you seen a change within your own professional expertise in how you now manage treating endometriosis to when you first started? And if yes, then what has led to this change?
so
Yeah.
coming to that question, I think I have been doing, I told you, endometriosis right from the starting 2000, early 2000s. And I would say the narrative then was availability of options, including ablation, including excision, including medical, including. So over the years, with especially getting more comfortable with diagnosis as well, extents of the disease. Personally, doing my own scans for the last 15 years, I can tell you that it's changed my approach to endo. And it's very, very clear now that if we have to do surgery, it's better off always to be an excisional surgery. So that is something that has significantly changed. I do not ablate lesions anymore. So I would say for the last 7 years or so, I may not have ablated any lesions. So that has changed in my practice, and I can tell that for sure.
Well,
Amazing.
I think for me, it goes without asking. I don't do ablation because you know from the early days there's no ablation. So, but let me talk from my own perspective. Mine was get patients coming in when we started learning about what endometriosis is. Just like any new physician is, once you start getting a new condition, you're now keen and you look for it. And so I would say my early days wanted to demystify the fact that there was no endometriosis in Africa. That's what we knew. So every time I put in a scope, let's say for any case, let's say myomectomy or just whatever, I would always go to, where the commonest site for endometriosis, which is behind the uterus, and then just kind of look at it. And I found that I was really picking up more endometriosis. But then again, I would say for me, when you start up, and this is something that's very important for us, I'll take it from a different context, which I know me and Dr. Amal have had conversation about it. And this is how aggressive you are in terms of treatment. So you find that when you're starting up, you're kind of aggressive in management, which again throws you to a bit of unwanted complication. Let me give an instance. When we started with resection of bowel, then you still kind of how much is too much. Then you go back to science and what the science is talking, what are the findings, what is the research showing. So I would say for me, it's what has really changed for me, it's just balance between for me, the most tremendous change has been how aggressive and how economical you can be in endometriosis, because you also need to preserve function of function of organs. So I think for me, that has been something that has been really phenomenal.
Amazing. You tapped into the part of, how the myth was that it was a Caucasian disease. And obviously here in Africa, we've been debunking that myth for a very long time. So what has your experience in dealing with endometriosis patients here in Kenya been?
Now, actually, for me, and I'm not sure for Yama, there's a lot of endometriosis. Oh my goodness. There's a lot of endometriosis. It's, oh my, I mean, with or without symptoms, you don't know how much of this that I see, and I know the same thing, Dr. Yama sees. I would say for me, the youngest I have is a 15-year-old with classical symptoms of endometriosis. and try medical treatment, doesn't work. It's very difficult to convince a mother of a 15-year-old that we need to put in a scope. You put in a scope, boom, there goes endometriosis. Sort endometriosis, the patient goes back to school happily ever after. So endometriosis, it's there. Just because it's not being reported or it's not being seen, I'll look into it. So let's look at what the problem is. Initially we knew that diagnosis of endometriosis was laparoscopy, but then we got to ask how many actually performing scopes. So that will answer the question. Okay. Then of course now that is kind of changing to ultrasound scan. Then we get at how many doing ultrasound scan dedicated for endometriosis. So the question I think for me is, the endometriosis in Africa? Yes, and a lot of it.
Yes, and I think maybe to add to that, what needs to be really done, and I see you and Doris and some other Esther and there are quite a number of you who are now taking it upon yourselves to create awareness. I mean, people like myself, him, and many other doctors are there to assist with the management of endometriosis. But we are too busy in our own lives and our own work to actually also do advocacy and also do the training or the awareness. So I think with introduction of menstrual disorders in schools, with introduction of the idea that do not normalize period pain as a normal, that is what that's where it needs to start. So treating endo is now, for the last couple of years now, and especially now over the last 1 year, Aarti, I kid you not, there is not a single day I don't see more than 5 patients of endometriosis in my clinic. And it's that bad. And more so now because I do detailed endometriosis protocol scans. Many of them are coming to confirm that they have endometriosis and how bad it is. So it's very extensively spread out in the country. It's only a matter of how quickly and how well we pick it up.
Wow,
So
no,
we should start very early. We should start as soon as the periods start. We should start from that age, trying to screen girls who are constantly complaining. And if we do that, I think we'll get to the level where we can pick it up early and not let many of them go into extensive disease, which is messing their organs up, the bowel, the kidney losses, the bladder nodules, etc., etc. So I think that's very important.
Definitely. And as much as you say you're busy not doing awareness work, you do it.
Yeah. No, I would love to do more. I'm saying I would love to do more. I've had discussions with so many of you, and I've said I would love to go to schools and give lectures on what a normal menstrual cycle should be like. That's the kind of advocacy and training I'm talking of. But you see, I don't get that time that often. So that's what I meant.
As soon as you train your the new age doctors, we will all have time to do it. That's our vision.
I think you're right. This is, RG, this is not a one-man show, again. And I really love this collaboration that started, coming on board and, still adding voice to what is getting done. I mean, look at what we are having right now. And also see again the partnership. When we started this conversation, I picked up from Dr. Yamal, and now we formed this collaboration. And you don't know how impressive these collaborations are. We consult. I'll call him and I say, I have this and this, and what do you think? Okay, well, I think this and this. Can we work on this patient together? And then who gets to benefit? The patient gets to benefit. So it has to be intentional. So there's no doubt about it. We have to be intentional about it.
Definitely. Dr. Yamal, you spoke about how you're so intensively doing your own scans now. And I'll be honest with you. So I've been battling endometriosis for I was diagnosed in 2004. And prior to that, I had it for a long time. I've had TVSs done.
A few weeks ago when I came to see you, I've never had such a detailed TVS done by any doctor. Like you were so detailed. It reminded me of, when you invited me for your workshop with Dr. Allen,
Yes.
and the way he was conducting it, and I was like, oh my God, I wanted to throw one of the patients off the bed, and I was like, I want to be there, just the way it was being done. And I was like, finally, had it done. So, that makes a huge, huge difference, especially again, as you said, in early diagnosis. So thank you for doing that, because I think also obstetricians need to do the TVSs themselves
Yes.
to a certain extent, to know, because you know exactly what you're looking for, and the way you maneuvered, what do you call the gadget? I'm calling it a gadget,
The
but I know
probes.
it's not.
The probe.
Yeah, the
Yes.
ultrasound scan
So
probe.
the way the way you maneuver it and check everything, the way you check the looseness of the organs, the tightness of the organs,
Yeah.
it's amazing, and that's how you know if organs are fused together or not. So it was like, for me, it was great. So thank you for doing all of that. So now, getting into the next question, what is it? Okay, this is one of the things that you offer, hence why I'm leading into this question, is that what is it that you offer to patients suffering from endometriosis, or those who have yet not been diagnosed with it, that is different from what is being offered by other obstetricians?
Do you want me to go first, Yaman?
Yes. Yes.
Okay. You see, I would not want to say one size fits all. So I would say we see all different patients. Now, for example, it can be a patient who has been seen by a primary physician, or who's been seen. So, or it can be a first-time patient who comes in, and this is the first time they're hearing about something called endometriosis, and you really got to make them understand what this whole endometriosis is about, and and what are the effects and so on. You're going to get patients who have been managed for endometriosis, who have heard about endometriosis, or some who have done their own research and think they have. So patients come from different, so you really gotta take every patient. You got to personalize the patient, and so what is their need? What is their level of understanding? And then what is their desire? What is their most the complaint that they have? Is it fertility? Is it pain? Because these are the two main symptoms that patients with endometriosis. And I would say, for me, it's you really gotta get deep into their soul and really empathize with them, and reassure them that, hey, look here, it's okay, their solution. But then again, you gotta be real with them. Let them understand what condition are we dealing with here. And this is, I think, something you mentioned, is you gotta be honest. You gotta be open with the patient. Let them really understand. And you also gotta appreciate the fact that this is going to be a long journey, and you need to prepare them that, hey, I'm not, we don't have a magic pill, or it's not one walk into the OR, come out, and then your life is completely transformed. You get it? So you really got to individualize patient. And once you connect with them, it is not the fact that, hey, we have a magic solution for you, but hey, this is the problem, but this is what we plan to do. And then again, maybe let Yamal mention this, then it's not a one-man show. You gotta have a team, and team, it just completes everything.
Yeah, so thank you, Dr. Jaggi, and I think to probably add a little bit of my perspective on that. Number one, endometriosis, we should remember, has a few characteristics. Number one, poorly understood. Number two, chronic. Number three, debilitating. It actually messes patients up. Number four, recurrent. This is a disease that has a potential for recurrence despite a very good clearance many times. Number five, affecting fertility, affecting pain and quality of life. Many patients with endo go to the extent of getting depressed. And that's why, like cancer support groups, endo is probably one of the only other conditions that has support groups. It's the only condition that leads to what is called chronic pelvic pain conditions and really messes those patients up for the rest of their lives. It affects the social background. It affects marriages. It breaks marriages. So having understood this about endometriosis, approaching it to cover what is mainly the goal of the patient is very important. All right. So if they come for fertility, our target becomes fertility. If they come for pain and quality of life, our target becomes that. And treatment, especially now that we are talking as surgeons who are dealing with endometriosis, is defined to be something that should be radical to the disease, but very conservative to the function. You don't want to also get rid of too much of the organ that you have a problem with bowel the rest of your life, or you have a problem with passing urine the rest of your life, or you have a problem with sexual intercourse the rest of your life. So we have to keep in mind radical to disease, conservative to function. So having said that, this is why endometriosis is one of those conditions that requires a multidisciplinary approach. And it's with this goal that actually, when I started doing endo, that we moved towards having a center that deals with endometriosis as a multidisciplinary team. And that's where myself, Dr. Njagi, we have a colorectal surgeon, we have a pain specialist, we have a nurse specialist specializing in endometriosis, we have a gastrosurgeon, we have a urologic surgeon, we have a psychiatrist, and we have a pelvic floor therapist. Now, this forms a team, and the whole team has to work in conjunction whenever dealing with a chronic pelvic pain patient, especially with endometriosis. So Third Park Hospital, for example, is one of those centers that has the full complement of these people.
Wow, that's great. I think Dr. Jagi is frozen. I think his connection is connecting. So Dr. Yamal, you beat me to my question of the multidisciplinary team, how important, now that you've tapped into it whilst Dr. Jagi joins us, you mentioned who's in your disciplinary team and the importance of it, because it's a cohesive team effort. Yeah. And that's what's the most important for the patient to benefit in case there's something going wrong in theater, then they can cater for all of it whilst you're all on board in the same room, right?
Sure.
Fine. So, okay, this is, I know I don't know what's happened with Dr. Jagi. Dr. Jagi, can you hear us? Okay, as he joins, I think his connection is an issue. Doc, why is it, I'm going to jump into a next question. Is there anything else you want to add into why the importance of multidisciplinary team is there, or we've already tapped into it?
I think for best outcomes, let me add one thing. The best outcomes, you need to have a complement of the right team, and you need to have the right equipment for diagnosis, and the right people doing the diagnosis. That's very important. And then finally, when it comes to the surgical treatment part of it, you need to have the right equipment. And with the most endometriosis teams worldwide, one of the things that really changes how the endometriosis surgery is done is, for example, 3D laparoscopy. So when you do laparoscopy, and then when you do laparoscopy in 3D, there is a difference because of the depth and the clarity of the areas you want to go. And because in endo we go to very detailed and deep spaces, I think 3D really adds to the quality of the surgery. So these are some of the things that I think I can add about a multidisciplinary team.
Okay, great. Thank you, Doc.
Sorry,
welcome
guys,
back,
my
Dr. Jagi.
internet is
No problem.
Is a mashinani
Oh,
connection.
bless. That's absolutely fine. We were just discussing we were continuing on when Dr. Yamal tapped into the multidisciplinary team and who is consistent of that team and the importance of it. Yeah. Okay. My next question is a question where, yeah, it's very, very touchy for everyone around the world, especially when it comes to endometriosis, especially for the patients. Why is it important to move away from the pharma-driven aspect of managing endometriosis?
Did you say pharmaceutical?
Yes, because you know what, we have a lot of doctors around the world. We have a lot of, you know, who punch in the medicinal, like, you know, medicines like Visan, Lutro, like, you know, a lot of the side effects are there. I'm on my tiptoes trying to tap into this conversation, this question. So if I overstep it, then I apologize. But let me know, you've understood it. Both of you are nodding, so you've understood it. So please take the floor.
Okay. I think it's important for me to give my, my as example, myself as an example. So when I did not have the right tools to make diagnosis, the right skill to manage surgical endometriosis, and had patients that you feel the alternative were, quite limited, then you did the very best that you could have done. And that was medical treatment. So if you, and I would want to assume this is the current situation. If you start, well, clinical presentation is that of endometriosis, painful menses and so on and so forth, but you've not quantified the amount of disease. And all that you have, all that the tool that you have in your hands is only pharmaceutical options. What are you going to do? That is the option that you're going to give patients. So if you have a hammer on your hand and you don't have a machete, I mean, you're going to try and use this, and I think that's the current situation. So you'll find patients now. And when you say pharmaceutical, I'm assuming you're asking the question in regard that I'm assuming this is endometriosis, not that just dumbling, and we have the right option, the Visane, the pain management option, which again, and we know the downfall to this is if you don't have the correct diagnosis or the stage of the disease. Let's say, for instance, you're giving medical treatment for a 4-centimeter nodule, it's not going to work. Patients are not going to get symptoms irrespective of what treatment that you're going to prescribe, DNRH and so on and so forth. I think we need to get to a point whereby if I feel the treatment is not working and I'm not, this is the only tool, can we refer to the next person that we feel that can actually manage endometriosis, either make diagnosis or else who can perform safe surgery for endometriosis. So I think you're very right. Let's say medical treatment has its role, but up to a certain point, whereby then if you lose it, then what is the next option of treatment? Again, we know surgical treatment can be employed in conjunction with pharmaceutical treatment. So again, it kind of depends. What I think, what my emphasis would be, can we really determine what kind of a disease are we dealing with? At what level are we dealing with? If at a certain point the patient is not responding to treatment, then we need to go, okay, that is first option. What is option 2? Which actually can be surgery. I mean, if you not have the skill to do proper ultrasound scan, then refer to someone who can do laparoscopic diagnosis for endometriosis.
Okay.
Yes, thank you. I think you've covered it very well, Dr. Njagi. And I would say that when it comes to the medical management of options available, there are logical reasons for when this is used, but it does not work on its own. So it has some role, but I would say the mainstay of especially endometriosis that is deep infiltrative or beyond, like in the ovarian endometriosis, might still be mainly surgical. I think that the role of medical management has been specifically mentioned. I would not use it for long. I would use it for patients maybe post-op for suppression or reduction of risk of recurrence, but it would not be the mainstay of treatment.
Okay, great.
Agree.
And I like how you covered also, obviously how transparent, Dr. Jaggi, you were, especially because Dr. Yamal, you've been doing this for a very long time, and how transparent you were about saying, because that was the only option you had, but now you've learned, the years have gone by, and there are now obviously surgery, excision surgery is one of it all. And the one thing that also obstetricians or gynecologists need to do is, if you can't handle the patient, please refer. I just feel referral is just such a priority for a patient for their treatment for endometriosis or any health condition.
Oh, absolutely. I think you gotta be on the right side, in the right team. I think it's amazing.
Fine. So, how many complex endometriosis surgeries have you done, and to what extent, or do you do weekly? This is only for statistics, but not statistics like fully blown into it, but this is just for our knowledge as patients.
I'll go at it first. I told you there's not a single day I don't see patients of endometriosis. So basically, I'm handling patients of endometriosis every single clinic of mine. When it comes to surgery, I would say, yes, I do quite a bit of surgery on endometriosis, ranging from simple surgeries to complex surgeries as well, involving up to the ureters or the bladder, the bowel. And yes, we now are looking at possibilities of going all the way to the thoracic and diaphragm as well. We are getting our team built up for thoracic. Where Dr. Jaggi has two patients. I have two patients that I've actually streamlined for thoracic. I mean, it's really messy. She coughs blood or has a hemothorax every period, which is really crazy. So we deal with a lot of those as well. In prospect, I think in the next 2 weeks, both Jaggi and myself probably have at least 4 to 5 surgeries, complex surgeries, already scheduled. So we do these regularly, yes, but we may not be able to give you exact numbers.
That's fine.
That's
perfect, but wow.
Yeah.
Wow. Oh, wow. That touches my heart when you spoke about the thoracic aspect as well, because the whole purpose of this conversation and this awareness about endometriosis here in Kenya is so that we try to see how the patients can get treatment here instead of traveling abroad, especially because of the cost and the financial aspect, which we'll get into it later on as well. So thank you, doctors, for doing what you're doing. So now you tapped a little bit onto this, and this is a question that I think is very, very important. How important is it to save healthy organs when excising endometriosis?
It's mandatory. It's not how important, it's mandatory. You don't get rid of healthy organ tissue. So your job is to get rid of the endometriosis, leaving behind all possible healthy tissue. That includes nerves that may be supplying these organs. That includes the vessels that are surrounding these major structures like ureters. You can't devascularize it, you mess it up. That includes leaving a bowel that is intact and functional. So basically speaking, it's not a choice, it's mandatory, and hence the difficulty, because this disease infiltrates into other organs like a cancer, but it's not a cancer. And hence getting the right plane to remove it from that organ but leaving the organ safe and complete is mandatory.
Yeah, yeah. I think just to add to that is, remember when we're treating endometriosis, we are already treating the tissue that has already been affected by endometriosis. The challenge is that we are not doing anything to the process, or what we call the pathophysiology, or the development of the disease. So being aggressive, you're not doing any good, and especially when years when this started with the colorectal surgeons, they actually manage the bowel the way they manage malignant bowel. And we knew that endometriosis is not it's not malignant. It's a benign condition, and its process of development is totally different from malignant. And I think this is what Dr. Yamal mentioned here. Again, this is a chronic condition. All we are trying to do is to manage and improve the quality of life. But you never tell the patient, oh, I'm completely going to clear your disease. Because the only way you can do that is to stop the process. It's really not very clear the pathophysiology or how the disease will develop. So I would agree that, it's not about how aggressive you are. It's how economical and respect tissue. Now, you mentioned healthy tissue. Again, I'll reiterate what Dr. Yamal said. Please leave the healthy tissue alone. And again, it really doesn't mean that you have the patient's symptoms. What is their complaint? And my early days is, what Dr. Yamal kept reminding me. If the patient has a bowel nodule which is 3 centimeters, they don't have a complaint. Just does it mean that it needs to be removed? Because, again, it gotta be the function that has to be preserved and take care of the disease and improve the quality of life.
Yeah. So let me yeah. Let me add to that. I mean, because it's benign, the major endometriosis surgeons of the world specify certain statements. One of them is you don't need a disease-free margin. So like cancer, you need a disease-free margin. Hence, if it's a nodule that big that is cancerous, they would go 2 to 3 centimeters above and 2 to 3 centimeters below, since they'll excise that big because they want a disease-free margin. You don't need a disease-free margin in endo. So if you have a nodule that big, you excise that much. All right. And if you leave a little bit of the disease behind, it's acceptable, but do not get rid of the normal organ with it. So that's the key of management that should be very clearly understood.
Right. And this is where, as you said, this is where informed consent comes into play, as it is anyway, right?
Yes. Sure.
Okay. And whilst you were talking about bowel endometriosis, also, salvaging the bowel, have you done any colorectal or bowel resections?
Yes.
Yes.
Yeah.
Yeah. I mean, I would speak from, of course, when we started along is multidisciplinary, and this is how we learn, as a team working together. But then you'd find that as time does go by, you will learn the skill on how to do this. And we've been to different centers where now what we should be talking about is what we call pelvic surgery. And pelvic surgery is, because remember, again, endometriosis is a gynecological condition, and we understand the disease of endometriosis, I think, by far, much better. So yeah, you're getting point where gynecologists or endometriosis specialists, they're able to perform their own resections with support from the gynecology, the oncologist. The colorectal surgeon, sorry, to be precise. So yeah, we at some point also doing bowel resections ourselves. And let me particularly put a disclaimer on this, is that endometriosis should be managed laparoscopically for very obvious reason, which I would not want to get started. So, and then you really find having teams. Let's say, for instance, the colorectal surgeon that we worked with very closely with, Dr. Jumba. You see, now we worked in Nairobi, we're in Mashinani. And, this patient have to be looked after. And there are different ways to do this. Is you learn the skill, you can apply the skill, but then again with support. So to answer the question, are we doing bowel resections? Yes, we are doing bowel resection. Are you asking individually or in conjunction with colorectal surgeon? Both ways, individually and with colorectal surgeons. Yeah, but it's very important. And I think Dr. Amal will agree with me when I say that you don't get surprises. So what I think is significant and is key is making the decision before you go to the operating theater. So, and how do you do this? By doing good imaging. So by the time you go in is, hey, this is what we are looking at. This is the much nodule you have. You're having discussions with the team. This is discussion, what do you think? How far do you resect? How far is, what is the patient's symptom? So it's not only whereby you go in and you put in a scope, you find, oh, oops, there's a bowel nodule. Okay, let's go ahead and say, no, that's not the way. So it has to be well planned. You have to prepare the patient. The patient needs to understand. The patient who say, no, go take care of the rest of the disease. When you explain to them, I'm okay. I don't have, bowel symptoms. So bowel can wait. So you really have to have this conversation. I would say, honestly, the surgery part, I would say, is the easy part. The decision and observation and all that we have talked before this, I think to me is the key. Is the core. Getting bowel is resecting the bowel is about to cut and then anybody can do it, but then which are patient candidates for bowel resection?
Right. So as very well put. In regards to levels of surgery, I think when I'm even training the younger doctors, I mention one thing. There are 3 levels of surgery. All right, for a good and an excellent surgeon. Number 1, knowing how to do surgery. That's very important. It's the first part. But a good surgeon will know not only how to do surgery, but he'll know when to do surgery. And a great surgeon will not only know how to do surgery and when to do surgery, but will know also when not to do surgery. So basically, the most experienced surgeon is the one who is the last one who has the idea of what to do, when not to do. So that is what a great surgeon should be able to do. So surgery is planned beforehand. When it comes to colorectal surgery, as I've said, we've even done a redo resection. Myself, Dr. Njagi, and Dr. Jumba as a team operated on one patient who had already had a colorectal resection, I think 7-8 years ago. And then she got another obstruction and we had to redo it laparoscopically. And Arthi, I tell you, with that kind of a surgery, you don't get any planes. It's a mess. It's very difficult. But we successfully did it in her. All right. It took us a good 11 hours of surgery. But yes, we managed to do it. So redo surgeries are the worst surgeries. If they were not, those are the most difficult surgeries.
Absolutely.
Yeah.
No, those are very valid points. And you're saying that obviously the steps that you've said about how the surgeon should do the surgery and what entails in it is very, very crucial. We've had a lot of comments saying great discussion. There was Faith saying that she's Dr. Jagi, she's one of your patients and you're very patient with her listening. You listen to patients. House of STL said, I hope I've pronounced that right. I've been on a journey with Dr. Yamal and Dr. Jagi and I could have not asked for better doctors. You guys are such a blessing.
Thank you so much. Yeah, thank you.
Thank you. Okay, so we've covered, we've done the success. What is your success rate in treating endometriosis, and what is your approach to excision surgery for endometriosis? I think the latter we've covered. What is your success rate? Tipping on toes again?
I'll let Yamal go first.
I would say it's a very varied answer to that kind of a question. I definitely would not say that all the patients I've operated on have never required another surgery again. Go down a few years down the line, the disease recurs, we go back in. The first time you do a surgery, you went in as an emergency because the patient developed an abscess and has pus inside due to some procedure done on her, and she also has endo. Your goal at that time is to deal with the pus and as much as clearing the pelvis of that infection. So you don't do a complete job purposely because you can't. It's a messy abdomen. So there are times that I would say when you look at success rates, it's varied. What are you looking at? Is it pain? Yes, we significantly improve the pain. Unfortunately, some of them develop it again in a few years or whatever. Is it fertility? I can boast and say I have a number of patients, even now following a grade 4 endometriosis surgery, who've had pregnancies and are currently ongoing. Many of them have required IVF. That's a different story because their tubes are already damaged as it is. They were stage 4 diseases. But even with IVF, getting a patient of that kind pregnant gives us so much pleasure. Trust me, it's like you've won the World Cup. That's how we feel. When such a patient gets a baby in the hand, we've won the World Cup. That's how we feel.
Again, I think you're right. Just let's say, for instance, the way the oncologists rate their success is when they say, you've done a surgery and then the patient is, has this percentage 5-year survival rate. I mean, that's how, they kind of scientifically. We really don't have that very clearly for endometriosis, but if you have no recurrence in 5 years, awesome. Again, I would say, just as Yamal said, I would count my success in different ways. Number one, what was my my feeling with the surgery? How do I feel the surgery went? That's number one. How I feel, clearing of the disease, how extensive the disease was. So I think that's, personal rating. Again, the best thing for me is when a patient calls you and tell you, hey, this has been my best menstrual cycle in the last 10 years. Let me tell you, that is like, I'll be like, oh my goodness. Or a patient calls you and say, hey, I just had this IVF cycle, again, just as Yamal said, and it was successful. So when we look at success, it gotta be, what was your objective in the treatment? Was it fertility? Was it pain? Was it, and then we can only follow this patient. But again, as we said, this is a chronic condition, and it depends on how early do you catch the disease and what was, how much disease did you get? Again, do I feel if, it was a stage 4 and extensive disease and then you've operated, the patient comes back for your operation, would I count that as a failed success? I think no. So it's very difficult for us to really say what is our success is. The question is, do we achieve our objective, patient's objective in that fact? And again, as I said, time does go by, I think time will tell. It's less than 5 years down the line. I've not had recurrence, so we can only wait and see what really, what really happens. But just to say this, we share a lot of our, our cases a lot, and that's one thing I feel very fortunate working with Dr. Yamal is, there are cases we work together. And one thing I have found particularly cuts across both of us is we'll remember almost every single patient that we've worked on. And when something good happened, we'd be like quickly to update each other. So, you know, it was the other day, a patient we operated a few years ago. You know, we did the first surgery. It was really difficult and to reoperate, and then she came back, you know, IVF, you know, and she conceived. And, you know, the moment she delivered, she called me, and guess the next person I called, hey, guess what? Remember that patient we operated? She actually has a bit, you know, I'll count that as a success, you know, on my side. Whether or not she's going to have a recurrence in the next 5 years, I think that part, we have achieved our objective. So I hope that's fair enough to, you know, explain that as our success in a way.
It is absolutely. You know what? I love the transparency and the honesty. So thank you so much. And this is what I said from the start. You know, I like working with you guys, but I love the transparency that's there. You know, and the honesty it makes you trust your doctor, as from a patient perspective.
But then again, you see, Artie, you know, first of all, you gotta be honest with yourself. And we as doctors, we got to remind ourselves that we are dealing with pathology, and this is pathology. And if you can give it your very best and be honest with yourself, I think that does not only make you a better clinician, but it makes you a better human being.
Definitely.
And you see, Aarti, in regards to this specific condition, seeing what these women go through, I can confidently say over the last 15 years, all my endo patients are in one log. I have a diary of endometriosis only. I have every single patient recorded there, because these patients are very special and close to me at heart. And definitely each one of them, the way Dr. Njagi said, we try and see, we get as much updates from them as possible. At least those who have been on follow-up with us, we would definitely have all their records. So it is something that is very important, that we understand what they want and we focus on what the goal is.
Absolutely.
Right. You have another patient testimony over here, right here. Habs.k. Sorry, I don't know your full name, just reading your handle. Dr. Yamal did my surgery and management in 2018. Endometriosis is still at a bay. Thank you, doctor.
Thank you.
Amazing.
Right. So, docs, what are the potential risks and complications of surgery? I think we tapped into it earlier on. Is there anything you'd like to add on to that, or it all depends on once you're inside and seeing how bad the patient may or may not be?
Again, as I said earlier, is that you really need to have a good, clear picture of what you're going to do, and this is where we are shifting from laparoscopy as diagnostic tool for endometriosis. Because what does that mean? You're putting this patient two surgeries. One is for diagnostic laparoscopy, because you might not be able to perform, or you might do laparoscopy for diagnostic laparoscopy, and then you're expecting is going to be a peritoneal disease. You find it, and then you get a abort. So what is actually very impressive and good is that now we can make these decisions before by doing good imaging, ultrasound scan, MRI, name it. So you already have clear, almost certain that we are going to, this is what we're expecting. So it's not going to find you by surprise. When you put a scope, everything is stuck together, you don't see what is under. So you will really you have a clear discussion with the patient. As we said earlier, as much as you're discussing with the patient, this and this and this and this is what we, looks to be effective, and this is what we plan to do. And if we do this, these are going to be possible complications. Possible complication can be bowel injury, it can be ureteric injury, it can be hemorrhage, it can be so on, so on, so on. But, you will have this clear discussion with the patient. But we'll do the very best that we can. Again, patient safety, number one. So it doesn't matter what we are doing or how much the disease, this will always remain our priority, and our priority is always going to be patient safety than how much of the disease that we can clear. Of course, this is the beauty of working with a multidisciplinary approach, and that is going, if you have a complication, you have a team coming on board helping you, sort it out and fix it. So again, you find that it all works out together. It's an all-rounded approach. But then again, I think I keep emphasizing, and then we should reiterate that you don't, in endometriosis, you have very little room for surprises. It should not be, oh my goodness, this is what we're finding. That's a boy. It's not good for the patient. It's not good for you as a clinician. Or you're being too aggressive, and then patients who went in and you had promised them everything is going to be all right, they're coming up with with a colostomy bag. So I think it's good to know what is my capability, what a possible outcome, and what a possible complication.
Dr. Yamal, you good?
Yes, I think that's well covered. I mean, the complications are across the board. Ask any gynecologist who is doing surgery. I do lots of surgery of different kinds, and I can tell you without a blink of an eye that the most complex surgeries are the endometriosis surgeries. It's not a routine surgery at all. So complications therefore go with the complexity of the disease. So vascular injuries, bladder injuries, bowel injuries, ureteric injuries, kidney losses. Kidney losses is more due to the disease than actually due to a surgery. But what I meant was name it, and they're all there. And hence that I think is just across the board. But just to remember, it is the most complex surgery we can deal with.
Absolutely.
Dr. Yamal, your patient said that the cherry on top for her was a baby, the one who did the surgery with you. Dr. Jaggi, Faiza has said, Dr. Jaggi is an amazing endo specialist. 1 year down the line after surgery, and now I can have a life during my periods and even go to school, which was a challenge before diagnosis and the surgery. Dorothy has said, Dr. Jaggi did my operation 3 weeks ago in Malindi. I can't wait to have a painless period. Thank you, doctor, and God bless. Pesh, I'm going to touch into that in a bit. She's asked about the costs. That was my next question, as it is. How accessible is excision surgery for endometriosis now, and how affordable is it? And if you want to tap into the question that Pesh has asked, is kindly touch onto the cost for the ultrasound and the surgery.
So I think I'll go at that first. I think in regards to endometrial, I mean the ultrasound and diagnosis, that's as a routine ultrasound anywhere. The cost is similar to anything like that. I told you I do my own scans. They come as part of my consultation, so I don't charge a separate charge for ultrasound. I think Dr. Jaggi does his own scans as well. So basically, that's part of our visit. So when you come to see us, that's an inbuilt component. Surgery now cost is challenging to answer because it depends on the complexity and what we end up doing. If, for example, it goes all the way to bowel, then bowel, if there is involvement of staplers and excision and resection, I mean, all those gadgets and all that we use are extremely expensive. Number two, surgery of these kinds take quite a long time. They are long surgeries. They're not short surgeries. When they're long surgeries, the cost goes higher because your consumables, the gases and the anesthesia gases and anesthesia drugs are all being used per minute. So how does everything steps up as time goes higher. So it is not an easy question to answer. Even when we discuss preparation for our patients for surgery in endo, we actually just give them estimates. At least I give them estimates, because the rest depends on what we will do and what we will find.
Thank you.
Dr. Jaggi?
Well, I think I don't think there's more to add to that. I would say that for me, it really depends on where I'm working at. I'm in Mashinani, and we're also working in Nairobi. As part of making it accessible, so if I'm in Mashinani, I charge for the ultrasound scan, because we try to also keep the cost for consultation a little bit low. But again, Nairobi, it's covered together with the consultation, just to be clear on this. In terms of surgery for endometriosis, I don't think I could add more than what Dr. Yamal has added. The only advantage I find myself is if I'm in a hospital in Mashinani, the cost can sometimes be, subsidized. But by and large, I would say the cost depends on the surgery, what the equipment. So if I'm using staplers or I'm using clips, the cost of me in Nairobi doesn't really, I'll still get the cost of, similar amount, either I'm in Nairobi or I'm in Mashinani. So I would say that it's really difficult to really, give a figure that this is what it would cost for surgery for endometriosis. Yeah, is that fair enough?
That's fine.
Yeah. Because,
now that you
and I think,
mentioned
let me say
Mashinani,
that, just to add to this, what we found is, and I think this is okay, for me, who has to discuss with the patient the cost of the surgery. So some patient will come and say that, oh, this is fee, but my friend who referred me to you, this is how much you charge them for the surgery. And again, it's your surgery is totally different from the surgery. Endometriosis stage 1, stage 2, stage 3, stage 4 is different. So I try to make it clear what your surgery is going to entail, and where there's a bit of issue, either myself or my office will try to explain to the patient what the cost is entail, and by most of the patient really understand the cost. But I would say honestly, by far the cost is locally is much affordable than you would compare it abroad, in my opinion.
the only sad part about it is that obviously, from a patient's perspective, especially a lot of the local patients, a lot of we don't have the government here who help us the way a lot of governments abroad help. And that's the challenging part of it. But now, leading from that perspective, and you mentioned Mashinani, please, for the viewers who don't know what Mashinani is, explain what Mashinani is, and please tap into a little about your Mashinani project, which I think is just incredible. Please don't be humble about it, because it's amazing what you're doing, both of what you guys are doing with the Mashinani project. And you know what? It's, again, you're doing this so that whoever can qualify for this qualifies, and you change their lives. With this, we're approaching the end. So please speak about your Mashinani project.
Okay, so I would start by Mashinani. So what it is actually, it's laparoscopy Mashinani. It's for those who don't understand the Swahili slang, Mashinani means rural setup. It's rural, so you can actually say laparoscopy in rural. So this is something that started a few years ago, and me, Dr. Yamal, and Mildred, who is a trustee as well, we needed to answer the question of accessibility which had been one of the biggest challenge. Again, this is, really justifies my earlier statement that endometriosis should be managed laparoscopically. So if you have a few, clinicians who have skill in laparoscopy, that means you even have a fewer number who can sort out endometriosis, because as Dr. Yamal has put it, is the most difficult gynecological surgical procedure. So just amongst ourselves, we felt that how can we, really improve accessibility? And what we came to figure out was that actually the limitation for accessibility of laparoscopy, which again, this will be another topic. I feel that laparoscopy is mostly needed in developing countries for obvious many reasons, was only for one reason, that there were no skill that was being passed to different clinicians. And honestly, and not, again, you told me not to be what's the right word, very humble about it. I really felt that having trained under Yamal, I really needed to also, it's what you call passing on the baton, and, passing on this baton. Mm-hmm. And we felt that we needed to bring these skills to the common monaingio, which majority were patients who are living in mashinani. So we started this movement. We called it laparoscopy mashinani, where we invited doctors to come and tag along, and we trained them, and so it was a double sword. So patient benefited and clinician benefited. So we allowed them into our OR, and we showed them how to perform laparoscopy and so on and so forth. So we worked together. And I would say that in the last 3 years, we should have, done more than 400 to 600. We don't even keep the numbers. We just do it, and these are either free surgery or subsidized with NHIF, whatever. So we'll just camp, and we go to a facility, and we say, okay, fine, we're here, doctors, and then we work. It's more of a friendship. Since you mentioned, I should say we just came from Eldoret last week. And this is a training institution, and we had been invited to go and train, so this is what the mashinani whole concept is all about. Now, when we did this, we felt that now let's tap into endometriosis, and this is where you joined us earlier this year. Was it this year? Yes, earlier this year. Yeah, earlier this year, where we said, okay, fine. Let's also bring in diagnosis of endometriosis, and we had a team, and we had more than 150, correct me if I'm wrong, Yamal, patients who actually benefited from free ultrasound scan for endometriosis. And you will not believe the numbers of patients who had endometriosis. I mean, this is something that we are going to write up, so I don't want to preempt this, but you could not even imagine. And I remember when we were talking the last few days, and if you're there, Dr. Aline Constantine, who had come from Germany, the last day, this guy actually in the hall, he just sat and he just wept. And I remember the conversation was that we always known this whole time there's no endometriosis in Africa. And me seeing this much endometriosis, this much bowel endometriosis, it was unbelievable. So this is the whole issue about laparoscopy mashinani, is we're trying to bring in accessibility, training, and talking about it. And I should say, since you think this is coming to the end, really humbled that you could have us, talk about this. I would say the passion that I have for laparoscopy, endometriosis, could not get it from a better person than Dr. Yamal, who's been a great mentor, and I think I call him my brother now. So you can really see by this conversation, you can see we have so much in common. It's like we read, it's like we are reading the same script. He's in Nairobi and I'm in Kirinyaga, but our mind process is the same. Our excitement and it's just the same. And I could not have been happy. I think I've done justice to mashinani. Yamal, do you have something to add?
Yes. I think you definitely have. If I can just for Aarti and the viewers tell you what our main activities are through the year. We actually have a calendar. At the start of every year, we have a board meeting, and our main activities revolve around camps. So these are medical surgical camps. So whether it's the diagnostic camp that we did, or a surgical camp, or a medical camp. So camps where we go and do free surgeries. And many of these are supported by some industry or some well-wishers, because there are costs involved, and there is some subsidized cost that is raised by the NHIF that these patients may have. But then the surgical aspect, the anesthesia team, the volunteers who come with us, the nurses are paid nothing. Those are from our pocket. That's one activity. The second activity we do is training. I think there's only so much that we can do as a group. I mean, we are small, and the extent of disease out there is phenomenal. There's no way we can cover that. So the second aspect is training. We train more, and they start continuing pushing it forward. So that way we get access to everybody much faster. So that's the second activity that we mainly take care of. So this is, and when we talk of training activities and all, we don't limit ourselves to Nairobi. I mean, to only rural Kenya. I can mention how far we've gone. We've gone to Uganda. We've now planning something in Tanzania. So we've been doing our activities in the region rather than only in Kenya.
Amazing.
Yeah,
Absolutely
and I think
amazing.
maybe it's also fair, Artie, to mention, because I know Dr. Amal would mention it, but it's important to mention, as much as we are talking about mashinani, there's also a lot of work that's been done.
Yeah.
I remember when still training under Dr. Amal, he was really passionate about training. And I I still remember him telling about his dream about having a facility that would increase on accessibility and training. And a year ago, he had this center, and you've been there, Third Park, which has collaborated much. And I still remember the opening day. I could see his eyes, man. They were just like glowing. And I think and I remember him saying, man, I can see my dream is coming true. And I really feel that we really don't do this for ourselves. And this is what I have learned from him, is that it is for the next generation that will come. And I tell my patient, I do this maybe for my daughter, or people who are dear to me, because who knows. And if the question is, how can we leave this place better than we found it? And even if it has to be just a little bit of it, that we can leave this a better place, I think we would have done this nation much good. So I want to say, as much as we're talking about mashinani, it's in all spheres and in all dimensions. So you go to Nairobi, you really find Third Park, and I'll tell you, every month there are trainings which are coming. Every month there are trainings which are coming. So I think for me, I would say there's really going to be no excuse that clinicians will say, oh, there's no opportunity for us to learn. And I'm looking at it with what you're doing, phenomenal, commendable work, and what some of us are doing, and what we are seeing a lot of other young gynecologists really create, building this interest. This additive energy. Trust me, and I promise, and I put this to record. If we have this in the next 5 years, reality will become different.
Absolutely. Absolutely. You actually, talking about your mashinani, you have a beneficiary who's on here as well, called Noreen Gami. She says, beautiful, true Rotarian spirit as much as you are, doctors. She's a beneficiary. We have Enda Strong, who's Dr. Shilpa from India. She says we need more such surgeons. We have Doris saying, well done, doctors, for mashinani, your expertise and your passion. Please document your findings. I'm not tapping into that, but yes, because it's in motion, so I don't want to do anything from that. But yeah, so it's amazing, and thank you. Is there any parting words before I show my gratitude to both of you that you would like to say?
Well, I would want Dr. Amal to give the last parting shot here, because I think I would say, and I'll keep repeating what I've always said in my social media, in my videos, and name it, is that and I put it in singular, but now I put it in plural. We will not go to rest, and I can tell you this for myself, and I can speak for Yaman as well, because he would speak for me as well. We will not go to rest until we have solution, because we believe that local problems needs local solutions. So we will without any doubt get solutions for all these problems, more so endometriosis. You don't know, Artie, you don't know how far and deep and high that we go, including, sacrifice that we do in our own personal life, and I would mention this coming month, we are out of the country. We will be in Rome for God knows how many days. I don't want to get started, but you cannot imagine what some of us are going through to make it to this, to this Congress. It cannot pass without, come again in August. I think we'll be away for almost a month. So I mean, these sacrifices, we're leaving our families, we're leaving our private practice, we're leaving our comfort, and this is again not for us, it's that others can benefit. So parting shot is, we will not go to rest until we have found solution for these monster called endometriosis, without a doubt. That is my parting shot. Thank you so much, Archie, for having me on this show. I really truly appreciate it.
Thank you, Dr. Jaggi. Thank you, Dr. Jaggi, and thank you, Arti. I think very well put, and my sentiments totally. I hold endometriosis very personal. I have got a couple of my patients ask me this one specific question. Dr. Yamal, what made you go for endometriosis? And I can tell you that it's very personal. I have not only been a doctor who's been dealing with the laparoscopy for many years and endometriosis for many years, but I can boldly say, yes, my wife is an endo warrior. All right? And now that is what kicked me to go into this. All right? Having had 3-4 surgeries, it's not a joke. So when I saw that, it totally changed my approach, and my passion just grew manyfold, exponentially, into making sure other women do not suffer from endometriosis. So we will not stop until we get the right and the best care that endometriosis can have in this part of the world. That's my parting shot. Thank you very much, Arti, and it was a pleasure having you with me, my brother. And thank you again, everybody who's been watching.
That literally gave me goosebumps, like seriously. This is why I have both of you doing this live with me, and it is my honor and my humbleness and gratitude towards both of you, because this is the narrative that we need to change here. This is your passion, your transparency. It oozes off both of you. It literally the passion that you have oozes off you all. And it's been an incredible session. I cannot thank you enough. And this is just the first of many yet to come, you know. So thank you, Dr. Yamal. Thank you, Dr. Jagi. Thank you to all our viewers for staying tuned with us through and through. And I really hope it's been informative. And you can reach both the doctors. You have their handles on here. And thank you for all your comments. Do you just want to scroll through the comments? There are some for all of us. Everyone's saying thanks. Thank you, Doris. Thank you, Dr. Shilpa. Tasha, I think, is saying Dr. Yamal is one of the best, and I thank God for him. Dr. Jagi, one of them said, bless your hands. So it's been a really informative and an incredible session. I cannot thank you both enough. And keep doing what you're doing. And here's to the climb being higher and higher. Okay,
Thank you.
take care and have a lovely evening. Thank you.
Thank you so much, Arti. Thank you so much, everybody.
Bye.
It's really a pleasure.
Bye.
All right. Have a good night. All right. Thank you, everybody. Bye.